Hey guys, and welcome to part 3 of our interactive cardiology high-yield questions and answers video series. If you haven't seen parts 1 and 2 yet, go ahead and check them out on our channel so you get the idea of these videos. So let's not waste more time. Good luck, here we go! Question: what is a coronary artery disease and which conditions does it include? Alright, so now as you can see here, we have divided the coronary artery disease into acute coronary syndromes and chronic stable angina. The coronary artery disease itself is a group of symptoms that present as a result of decreased blood flow through the coronary arteries that supply the heart muscle with blood and oxygen, which will lead ultimately to cardiomyocytes damage and necrosis. The decreased blood flow through the coronary arteries is due to increasing accumulation of lipid-rich deposits on the lining inside of the vessels, as you will see in unstable angina and nonstemi, which can eventually rupture these lipid-rich deposits and can cause the formation of the thrombus, which will occlude the entire lumen, causing ST elevation, myocardial infarction, or the so-called STEMI. Question: can you tell me how do you diagnose unstable angina, nonstemi, and STEMI? Answer: all acute coronary syndromes will present with acute typical chest pain, which is also called angina. And what does it mean? It means pressure-like substernal chest pain radiating to the left arm and jaw and lasting more than 20 minutes, provoked by exercise or emotions, and it is relieved by nitroglycerin. And again, in unstable angina, the plaque is small. The lipid-rich deposits, which we call plaque, is small, but still big enough to cause ischemic chest pain when the patient is exercising and the blood supply cannot meet the heart demands. And keep in mind that this pain here can occur even at rest, and this is the way to differentiate from stable angina, which we'll discuss in a bit. On EKG, you will see non-specific changes and the cardiac biomarkers will be normal, since no cardiomyocytes death has occurred. Nevertheless, this condition is very dangerous and needs immediate treatment, as you'll see in a bit. In nonstemi, the occlusion of the coronary artery is still incomplete, but is much bigger than the one in unstable angina, which can lead to subendocardial ischemia, presenting on EKG with ST depression and T-wave inversion. And of course, the cardiac enzymes will be here elevated due to necrosis of the cardiomyocytes. In STEMI, on the other hand, the occlusion is complete, which leads to transmural ischemia and death of even more cardiomyocytes, which will spill out the enzymes they contain for us to find in the patient's blood. The most sensitive and specific is troponin I. On EKG, you will find the characteristic STEMI changes. Memorize the STEMI criteria as we discussed before, as it will come in handy. And don't forget the ST depression in V1 to V3, which is basically a posterior wall STEMI. Question: in the emergency room settings, what drugs should you immediately start your patient on when you diagnose him with STEMI? I need 7 classes of drugs here. Now, if the patient presents in the ER settings with acute chest pain, you do an EKG and you diagnose STEMI. Now, you have sent already for the troponin I, but you already know that it will come back positive. So as you start the following meds, you should simultaneously estimate whether you can send your patient to the PCI unit or give him thrombolytics instead, which we'll discuss also in a bit. The mnemonic we use here is the BOXMAN, which includes beta blockers, oxygen, morphine, antithrombotic drugs and nitroglycerin. Now, I'm intentionally leaving out the ACE inhibitors and the statins, even though they do have mortality benefit, since you don't need to start them in the ER room. They are not emergency drugs. You can start them later on, for example, after the PCI is done. But if you can start them immediately, if you have time, then start them immediately. Okay, so from the beta blockers, the most commonly used one is IV or oral metoprolol. If you start with IV, you should switch it to oral after the patient has been stabilized. Okay, OX stands for oxygen to keep the saturation high, M is for morphine to decrease the pain, and A stands for antithrombotics drugs. Now here we have two antiplatelet drugs, which are the aspirin and the P2Y12 inhibitors, and one anticoagulant, which is heparin. Now aspirin has mortality benefit and it is time dependent, so you want to give the loading dose of 325 milligrams ASAP. Then you need to continue the patient on 81 milligrams indefinitely. The second antiplatelet we use is one of the P2Y12 inhibitors, also known as the ADP receptor blockers. Now we have 4 of them, but in STEMI you want to use either clopidogrel, which is the most commonly used, prasugrel or ticagrelol. The third antithrombotic is the anticoagulant heparin, and we have several types of heparin, and they all work by blocking the coagulation cascade, thus preventing the thrombus formation. The one heparin with mortality benefit is the low molecular weight heparin, which is called enoxaparin or Lovenox, which does not increase the APTT, by the way. Now, if your patient is having severe CKD, which by the KDIGO guidelines is defined as GFR less than 30 milliliters per minute, or you know already that you will be sending your patient to the PCI unit, it's better to use the unfractionated heparin, which will allow you to monitor its therapeutic levels with the APTT levels, which stands for activated partial thromboplastin time. You can also use here fondapaurinox as an alternative to enoxaparin, as you don't need to monitor drug levels with APTT as well. N is for nitroglycerin. Nitroglycerin as a venodilator, it will decrease the preload to the heart, it will decrease the ventricular wall stress and also the oxygen demand. And remember, never use nitroglycerin in right ventricular wall MI. Why? Because the infarcted ventricle is very much dependent on the preload. And instead of reducing the preload by giving nitroglycerin, you want to give them what? IV fluids. Awesome. Now about the ACE inhibitors, like I said, they have mortality benefit by stopping the ventricular remodeling and dilation, and any one of them will work. And again, the ACE inhibitors are the PRIO drugs, enalapril, captopril, ramipril, etc. And again, if you have a patient who is intolerant to the ACE inhibitors, you can try to give them one of the ARBs drugs, which are the sartan drugs, valsartan, candesartan, olmesartan, etc. The statins here you want to use are the high-intensity statins, which we have 2 so far, rosuvastatin and atorvastatin. Question: once you have stabilized your patients with the BOXMAN pneumonic drugs along with the ACE inhibitors and the statins, what do you do next? What 2 options do you have to unblock the stenosed artery? Answer: in order to meet the end goal of the treatment, which is to unblock the occluded coronary artery, you have 2 options, either PCI or fibrinolytics. Now you can send the patient to the PCI unit within 90 minutes of entry in the hospital, called the DIDU time, door in, door out time, or within 120 minutes of an entry in a hospital without the PCI unit. Here they give you additional 30 minutes in order to transport the patient to a facility with a PCI lab. Now, if your initial estimate is that you will not be able to get the patient to the PCI unit within the allotted time, should start him on thrombolytics within 30 minutes of hospital entry. Question. Now the patient is at the facility where they have PCI unit. What are your two options there depending on the degree of vessel occlusion? Answer. If the occlusion is less than 70%, then you can perform balloon angioplasty. And if the occlusion of the coronary vessel is more than 70%, you can put a stent there in order to keep the vessel open. Now both procedures, as we said, aim to widen the lumen and restore the blood flow. The choices of the stents are also two, either bare metal stent or drug-eluting stent. Now remember, if you put the bare metal stent, you need to keep the patient on dual antiplatelet therapy for a minimum of 1 month. But we actually prefer to put the drug-eluting stent due to lower rates of restenosis. The downside here is that you need to keep the patient on the same regimen of dual antiplatelet therapy for minimum 1 year. Question. How do you manage nonstemi and unstable angina patients? Answer. Luckily, the initial drug treatment is the same as the one we discussed in STEMI. The same box mnemonic along with the ACE inhibitors and the statins. With the only exception here is that the most beneficial P2Y12 inhibitors here are the prasugrel and ticagrelor. After you have started your patient on these medications, you have to evaluate his mortality risk and the risk of major adverse cardiac events by using the TIMI score. Now, based on the number of points the patient receives using this TIMI score, you will manage him differently. Now, can you think of the 7 points for the TIMI score here? Okay, the 7 points of the TIMI score are as follows: 65 years or older, more than 3 risk factors for coronary artery disease, aspirin use within the last 7 days, more than 50% coronary artery stenosis, ST changes, positive cardiac enzymes, and 2 or more than 2 anginal episodes. Now, how do we interpret the TIMI score? Alright, so if the patient gets 0 to 2 points, he doesn't need any invasive procedure. His mortality risk is low, so we need to send him to do an exercise stress test, so we can check if we can induce ischemic changes in his heart. And we'll discuss the stress test in a bit. Whereas if the TIMI score is between 3 and 7, you will need to send this patient to the PCI lab, because he is at high risk. And again, if you find more than 70% stenosis there, you can put stent or plan for CABG procedure. Question. What is a chronic stable angina? Answer. The patient with chronic stable angina will present to the office with history of pressure-like chest pain that occurs only with exertion. That's how we differentiate it from unstable angina chest pain. Like we said, there the pain can occur at rest as well. And here the pain in chronic stable angina is also relieved with rest. Now, the cause of the pain is again narrowing of the coronary artery due to buildup of atheromatous plaques. In comparison to the Prince metal angina here, or cocaine abuse, where the same chest pain is caused by coronary artery vasospasm. Question. How do you diagnose chronic stable angina? Can you fill out this diagram? The mainstream is exercise stress test. How it works is you get on the treadmill with attached electrodes and you start walking or running till you reach a goal heart rate of 85% times 220 minus the age of the patient. You have to memorize this formula, it will come in handy, I promise you. Now here comes the tricky part. What do we do if the patient cannot exercise? And why the patient wouldn't be able to exercise? Well, imagine the patient has amputated limb. or he has osteoarthritis, or he has had previous ablation, or low heart rate, or he is on beta blockers that you should stop 48 hours before the test, by the way, or he is on calcium channel blockers or nitrates. Now here we can perform pharmacologic stress test with dipyridamole or adenosine plus thallium scan. Or we can also perform dobutamine and echocardiography test. In patients with EKG changes at rest that can interfere with the interpretation of the exercise stress, we can use the exercise thallium scan and exercise echo. Question: how do you define a positive stress test? Answer: if during the stress test you noticed early ischemic changes on the EKG, which are ST depression more than 1 mm, ST elevation without Q waves, or drop in systolic blood pressure with more than 10 mm, these are all positive stress test results. Then you have confirmed stable angina and you need to send your patient to the PCI unit to determine the vessels involved and the percentage of their occlusion. Question: what are the next steps in the management of your patient with chronic stable angina, depending on the percentage of vessel occlusion? Can you fill this table out? Answer: if the occlusion is less than 70%, you should start your patient on a guideline-directed medical therapy that includes aspirin, beta blockers, calcium channel blockers, ACE inhibitors or ARBs, statins, nitrates and ranolazine. And if the occlusion is more than 70%, you can put right there and then stent or schedule the patient for CABG procedure. Super high yield question: what is the duration of the dual antiplatelet therapy in coronary artery disease? Alright, so as you can see here, for STEMI, non-STEMI and unstable angina, you should keep the patient on dual antiplatelet therapy for 1 year if you haven't put any stent in them, if you have put a drug-eluting stent there, or the patient has undergone CABG procedure. And you should keep the patient on a dual antiplatelet therapy for 1 month if the patient has received a bare metal stent. Now, for patients with stable angina, they should receive indefinitely aspirin if no intervention has been done on them or if they have undergone CABG procedure. Now, dual antiplatelet therapy for 1 year, which includes aspirin and clopidogrel, is reserved for patients with stable angina who have received drug-eluting stent. And for those patients that have received bare metal stent, then you should keep the dual antiplatelet therapy, which is again aspirin and clopidogrel is the preferred one, for 1 month. Alright, and lastly, to shake things up a bit, can you tell me the current hypertension guidelines? What is normal BP, elevated BP and hypertension stages 1 or 2? Answer: the newest hypertension guidelines from 2017 are as follows. Normal blood pressure is considered blood pressure less than 120/80. Elevated blood pressure is blood pressure 120 to 129 over less than 80. And hypertension is divided into 2 stages. Stage 1 is 130 to 139 over 80 to 89. And stage 2 is 140 over 90 and above. Also keep in mind that isolated systolic hypertension is defined as blood pressure more than 130 over less than 80, and isolated diastolic hypertension is defined as blood pressure less than 130 over 80 or more. And patients with a blood pressure more than 130 over 80 are considered to have mixed systolic diastolic hypertension. Question: what is the treatment of hypertension? Answer: the treatment of hypertension also has changed a little bit. Beta blockers are no longer recommended as initial monotherapy unless the patient has heart failure with decreased ejection fraction or ischemic heart disease. Otherwise, you can choose one from the following medication classes: the angiotensin converting enzyme inhibitors, the ACE inhibitors, which are the prodrugs, or the angiotensin II receptor blockers, which are the ARBs drugs that end on sartan, the thiazide diuretics like hydrochlorothiazide and chlorothiazide, and calcium channel blockers, the dihydropyridine ones, the DPN drugs. Also make note that the thiazides and the calcium channel blockers should be used as initial monotherapy in African American patients, whereas the ACE inhibitors or the ARBs drugs should be used for initial monotherapy in patients with diabetic nephropathy or chronic kidney disease with proteinuria for patients from all ethnicities. Question: what is the ASCVD score, the atherosclerotic cardiovascular disease score, and when do we use it? Answer: we calculate the 10-year risk of ASCVD in all patients with an LDL-C levels above 100 mg per deciliter when they are not treated with any anti-lipid drugs. Now we use online calculators where we add certain patients' data and we get a score. And based on this score and the 2013 American College of Cardiology / American Heart Association guidelines about the treatment of blood cholesterol, we treat as follows. If the patient has a history of acute coronary syndrome, stable angina, stroke, TIA, PAD or CABG procedure, and if they are less than 75 years of age, then we have to put them on high-intensity statin. And we have only two so far high-intensity statins, which are the rosuvastatin and the atorvastatin. If the same patients are more than 75 years of age, then you have to put them on moderate-intensity statins. Now, if the patient has LDL more than 190 milligrams per deciliter and the patient is more than 20 years of age, then again he needs to be on high-intensity statin therapy. If the patients have diabetes, they're between 40 and 75 years of age, and their LDL is between 70 and 189, now depending on the ASCVD score, we're going to treat them differently. If in those patients the ASCVD score is more than 7.5%, then they get the high-intensity statin. If their ASCVD score is less than 7.5%, then they will get the moderate-intensity statin. Now, the last group of patients here that we are going to review are the patients who have no diabetes. They're between 40 and 75 years of age, and their LDL levels are between 70 and 189 milligrams per deciliter. Now, if these patients have ASCVD score more than 7.5%, it's easy, high-intensity statin. But if the ASCVD score is between 5 and 7.5%, then they will get the moderate-intensity statin. And if the ASCVD score is less than 5%, then they get no statin therapy. Alright, so I hope you enjoyed this video and you were able to answer all of the questions. Please feel free to share the link to this video on your social media if you liked it. Also, don't forget to subscribe and hit the bell button to receive notifications if you're interested in more high-yield USMLE videos to come. Also, you can follow us on Instagram. This is the name of our official Instagram page, as I'm posting there daily high-yield USMLE notes that I guarantee 100% that you will see on your USMLE step exams. I'm not gonna waste your time with material that is not high-yield or not heavily tested. And I'm also posting there the slides from our videos, as we are still in the process of creating free PDFs from our videos. So until then, you can check out the slides there on the Instagram page. Thank you very much for watching again. Good luck with your studies and enjoy the journey. See you on the next video.